Hello everyone, my name is Rosie and I did my presentation on cerebral palsy. Cerebral palsy is defined as a group of permanent disorders of development of movement and posture, which is caused by damage to the fetal or infant brain, and this can cause activity limitations. However, it is a non-progressive disorder, meaning that additional damage to the brain will not occur. Cerebral palsy, also known as CP, is the most common motor disability in childhood. About 1 in every 323 children has been identified with CP, and it is more common in boys than girls. I have a bar graph off to the side that shows the prevalence among 8-year-old children across 4 different states in the United States, and there's an average of 3,100 children per state who have been diagnosed with CP. There are 4 main types of cerebral palsy. The first one is spastic CP, and about 77.4% of children diagnosed with CP have spastic CP. This is defined as increased muscle tone or muscle tightness is another way to phrase that. There are 3 types of spastic CP. There's spastic diplegia, which is stiffness or tightness in the legs. The walking can be difficult because of tightness in the hips, which can cause internal rotation, and the knees kind of knock together, which is known as scissoring. The second type is spastic hemiplegia, which only affects one side of the individual's body. Usually the arm is more affected than the leg. And the last type of spastic CP is the most severe. It's spastic quadriplegia, which can affect all 4 limbs, trunk, and mouth and face. Oftentimes, additional developmental delays will also be seen with spastic quadriplegia. Another type of CP is ataxic, which affects an individual's balance and coordination. Movements with control, such as writing, can be difficult, and walking is also difficult. The last type is dyskinetic, which is a type in which muscle tone varies. So the muscles can be very tight and very loose, which can vary from day to day or even within the same day. Their movements are uncontrollable in all 4 limbs, trunk, and face. So activities such as sitting, walking, talking, and swallowing are very difficult for these individuals. And lastly, mixed CP is when individuals experience symptoms of more than one type of CP. Spastic dyskinetic is the most common type of mixed CP. And I included a picture at the bottom that shows all 3 types of CP where the brain was damaged, and it highlights on the body what parts of the body are affected. So how CP is diagnosed? There are 3 main stages. So the first one is developmental monitoring, which is taking your child to routine doctor's appointments, voicing any concerns you might see as far as motor and movement delays, or if the doctor notices any delays, then you move on to developmental screening, in which case they test for those motor and movement delays. These tests are done at 9 months, 18 months, 24 to 30 months. Cases of mild CP may be difficult to view at 9 months of age. However, by 24 months, the mild CP can be found. And so once those motor delays are observed, they move on to developmental and medical evaluations to diagnose a specific disorder. So the doctor or specialist would then test the child's motor skills, muscle tone, reflexes, posture, and take an in-depth family medical history. To further pinpoint a cause, brain imaging testing can be done, such as a CT scan or an MRI, or a combination of any of the various tests I have listed at the bottom. So cerebral palsy is a lifelong condition with no cure. However, there are treatments and medications to help the different systems that CP affects in each individual. I've listed 4 categories of medications here and their effects on, or how exercise may affect them. So antispasmodics and muscle relaxants may cause sedation, nausea, dizziness, or loss of seizure control. Anticonvulsants may cause fatigue, dizziness, or decreased cognitive function. Anti-seizures may depress the CNS, which is contradictory of exercise because during exercise we want to excite that CNS. And lastly, anticholinergics or dopaminergics may cause dry mouth, constipation, agitation, dysuria, which is discomfort urinating, and exercise may increase any of these side effects. So, should individuals with CP exercise? The answer is yes. Exercise increases and maintains heart and lung efficiency. It can maintain strength, flexibility, mobility, and coordination. Exercise will also maintain and improve bone structure, strength, and reduce the risk for chronic diseases such as osteoporosis and blood pressure, high blood pressure. So physical therapy is often the first step in treating cerebral palsy. However, there are some responses to exercise that individuals with CP may experience, such as incontinence. So they may not be able to control their bladder when exercising. Cognitive and behavioral problems may accompany exercise. Asking precise questions that require short answers. Giving the individual plenty of time to accommodate to new tasks is important. So repetition of certain exercises or activities is very beneficial. And then limiting the amount of instructions you give at one time can help with some of those cognitive and behavioral problems. Musculoskeletal problems are common among individuals with CP, so fractures, hip dislocations, leg length discrepancies, and bone loss may occur, so in which case you want to only bear weight when appropriate. Individuals who are prone to fractures may benefit from swimming. And then individuals who have hip dislocation or have had it in the past need to be cautious of putting any pressure on those hips to avoid a hip dislocation again. Oral motor dysfunction may also occur. Dysphagia is the inability to swallow, so excessive drooling may occur, in which case providing a towel for that individual may be helpful. And dysarthria is the inability to pronunciate or speak clearly, in which case asking simple yes or no questions, in which they could maybe shake their head yes or no, would be very beneficial. Seizures and epilepsy are often accompanied with CP, so knowing how those medications for seizures and epilepsy may affect exercise, as well as being aware of what to do in a situation if an individual is seizing during exercise, are very important considerations. And lastly, sensory and perception impairments. So breaking down instructions, giving cues for each activity rather than giving them the entire program can kind of limit some frustration and overwhelming feelings they may have during the exercise. And the exercise prescription. So the modes for cardiorespiratory exercise vary based on the individual's abilities. So anything from walking, running, cycling, propelling a wheelchair, swimming, and hand cycling are all excellent modes of cardiorespiratory. Swimming, again, is a preferred method for some individuals because the warm water may decrease someone with tight muscles or that high tone we talked about earlier, or vice versa. Cool water might be able to increase tone in someone with low tone. And this intensity should be performed at 40 to 50 VO2 reserve for someone who's just beginning, and it can be progressed to 50 to 60%. And this should be done about 2 to 5 days a week, 30 minutes at a time, or a day, I should say, because 30 minutes at a time may be unrealistic for some individuals because it's very fatiguing. So breaking cardiorespiratory training up into 3 different 10-minute sessions throughout the day may be more easily accomplished. And the next mode, or the next training method, is resistance training, in which machines and resistance bands are the preferred methods. However, if the individual has the balance and stability, free weights may be used under supervision. And these repetitions should be performed until fatigue, so starting with low weights and doing high reps is beneficial, and then progressing to higher rates and lower reps. This frequency should occur about 2 to 3 days a week, but avoiding consecutive days in a row. And the duration should be about 3 sets of 8 to 15 reps, and that should take the individual to fatigue per exercise. And lastly, range of motion activities should be passive and active stretching, and an example of that is PNF stretching. So the individual should maintain the stretch or range of motion activity until a point of slight discomfort, and this should be used as a warm-up or cool-down for other exercises or activities, and they should be held for about 30 to 60 seconds per stretch, about 5 to 10 times each. So there are some modifications and special recommendations for individuals with CP. For cardio training, you want to make sure that they are properly supported and positioned, and checking their skin for any rubbing or irritation if you're using aids or any motility devices. Again, swimming is an excellent cardiorespiratory training mode if there is a high fracture risk. And resistance training, you want to ensure sufficient joint stability and range of motion is performed correctly to avoid any injury. And lastly, range of motion, you want to ensure that the joints are stable, again, to perform that full range of motion. Oftentimes, motility devices are used with individuals with cerebral palsy, so this can include walkers, wheelchairs, crutches, orthotics for feet, ankles, knees, and hips. I have a picture in the center of the PowerPoint here that shows an individual using ankle orthotics to help support those ankles. And for my case study, I did a patient who is a 3-year-old female. She has spastic diplegia, which means only her legs are affected. She does use a walker. She was only crawling independently prior to the walker, so she was unable to walk and is unable to walk without her walker. She does wear ankle orthotics, and she doesn't take any medications at this time and has not been diagnosed with any other disabilities. So for her risk stratification, she is prescribed physical therapy twice a week for 1 hour each session. Walking without a motility device is unlikely for her. However, she's learning to use and move efficiently in the walker she has and build strength in those legs to maintain her ability to walk. Her risk group at this moment is walking difficulty. However, in the future, she may develop arthritis, hypertension, or osteoporosis. So her goals at physical therapy are to increase strength and promote independence, hopefully promoting or progressing to crutches rather than the walker, and crawling up the stairs independently. Special considerations for her include her age, so keeping in mind typical milestones, and also ensuring ankle, knee, and hip support during physical activity. And in conclusion, exercise for individuals with CP will give them all the same benefits that the general public would receive from exercise, in addition to increasing or reducing tone based on their needs to reduce that pain and kind of help ease their activities of daily living. However, it is important to make sure that they have planned exercise around their medication times, and that the special considerations are kept in mind to ensure safety and effectiveness during their exercise. And every individual with CP is different, and they have different needs, so each exercise program and plan should be individualized to tailor their treatment and their needs. And these are the references I used. Thank you.